Hello, I'm Dr. Greenaway, and this is the Cognitive Behavioral Therapy Training and Certification Program. This presentation is covering Course 200, also known as Level 200, and the main idea of this is application. So you should have already finished Course or Level 100, which is the fundamentals where you've read the material, you've taken the test, you've seen the presentations, kind of looking at an overview of cognitive behavioral therapy, some of the major tenets of CBT, where it came from, the theories behind it, and so forth. After this presentation, you should start to feel more comfortable actually applying the strategies and the ideas of CBT in the actual clinical setting. So let's go ahead and get started. The resources that a lot of this pulls from and which you can be using in your own clinical practice are the following. So we've got Overcoming Depression, a cognitive therapy approach. This is the book by Dr. Gilson and Arthur Freeman, Jane Yates, and Sharon Freeman. It comes with the therapist guide and the workbook that the patient would use that reiterates what you're working on with the patient. So I recommend getting those to use as well. And then we've got a lot of information. The book cover had a jacket on it, but now that's the cover, plain blue. This is Cognitive Therapy, Basics and Beyond by Judith Beck, the daughter of Aaron Tim Beck. And this book is used in a lot of universities in the CBT courses there. And it actually talks you through session by session and how to apply the strategies and theories of CBT. The other one that is widely accepted, very well known, is Mind Over Mood. I've seen so many different covers on this. This is by Dennis Greenberger and Christine Podesky. And this is also one that the patient would use, and it walks them through explanations of the tenets of CBT and specific strategies and homework assignments that would coincide with therapy. And another resource that's pretty much considered a must-have for any CBT therapist to have on their bookshelf is David Byrne's Feeling Good, the New Mood Therapy. Right here I've got the Feeling Good Handbook, which is has all of the different strategies and techniques that the patient can go through. It's a pretty thick read, so it covers a lot of territory. And his other one, which is When Panic Attacks, focuses on anxiety, but it's pretty much the same strategies, techniques. It's not specific to panic attacks. The title can be a little bit misleading. It's really about anxiety in general and applying the CBT strategies. So those are the two David Byrne's books that I would highly recommend getting and going through. And you'll see a lot of overlap among these resources. So what we're going to be looking at today, the outline for today's presentation, we're going to look at case conceptualization. When you have a patient, how should you be thinking about that patient and their issues in order to direct the therapy to go in the most effective way? We're going to look at principles to keep in mind in every therapy session. To do that, we are using the Cognitive Therapy Rating Scale. It's an actual questionnaire that you can use to rate yourself, or one person can rate another person reviewing a recording of a therapy session. If you're using it on yourself, you can basically, if you're not recording the session, you can go from memory and make sure you're including these aspects of CBT in your sessions. So it's a pretty helpful tool because it basically breaks down what you would look for in a session to be able to call it CBT and a well-rounded CBT session with all of the elements that have been shown to be effective. Then we're going to look at a CBT session outline, session by session, what you should be doing in the sessions. And then we will talk about specific CBT strategies and show you some examples of how you would apply them in actual sessions for common issues that come up. So let's look at case conceptualization. Why do we have a case conceptualization? Well, it provides the framework for the therapist's understanding of the patient. If you don't have a case conceptualization, it's easy to get off track and start to have what I call chit-chat therapy. Also, it helps highlight some of the primary concerns of the patient and make sure that there's a focus on those things. What should the case conceptualization answer? So for one, if you're in a practical sense, diagnosis. If you're using insurance, they're going to need a diagnosis and you want it to be accurate, and also the diagnosis can oftentimes help shape the course of therapy because the symptoms of the diagnosis are usually the goal list of correcting those symptoms. You want to know what current problems are going on. Not just I get anxious all the time, or I'm depressed and I'm down, but how do those issues translate to the day-to-day life of the patient? For instance, how are they spending their time during the day? Are they being productive? Are they eating well? Are they socializing? If they're not doing these things, that would probably be some of the common current problems in patients with depression or anxiety. Some other common problems would be things like being unemployed, or being alone and wishing, being alone and wanting to have some romance in their lives, or somebody who is finding that they don't have the kind of friendships that they want. So these would be considered current problems that would be addressed in therapy. And you want to find out, how did the current problems develop? When did this begin? Is it a phase that the person's going through? Is it a certain state that they're in? Or are they long-term problems that stem from personality traits that have been there for a long time? You want to understand that a little bit better. In CBT, you also want to look at how are current problems being maintained. A lot of times you'll see a loop where the problem itself is causing some type of issue, but that issue is also maintaining the problem. For example, a common one with depression, for example, would be the patient who's depressed and they are saying no to any invitations that they get from friends, and they're staying inside. And when you ask patients, why are you doing this? Why don't you go out? Or when do you think you'll go out? There's this common idea that patients seem to have, that they first want to wait till they feel better, then they'll start going out. And I'll oftentimes even draw on the board. I usually have a whiteboard that I use in sessions, and I'll draw feel better and then an arrow going over to hang out with friends. And then I show them that the arrow could just as well go the other way, where maybe if they hang out with friends more, they might improve their mood and feel better. So that would be an example of how the isolation, the not associating with people, is helping to keep the depression going. Also, in the case conceptualization, you want to look and see what dysfunctional thoughts or beliefs are associated with the problems. So you're trying to start finding out, what is this person's philosophies about themselves, others, the world, and the future, the cognitive triad. Which I usually like to think of as the 4 aspects. Instead of the cognitive triad, I guess it would be the cognitive quadrangle or something. Because you have the self, others. I like to split up the world and the future as 2 separate things. Some readings that I've looked at say self, others, and the world. Some say self, others, and the future. But you want to look at their thoughts and beliefs about these aspects and start to understand what their schema system is. The other part of case conceptualization is what emotions and behaviors are linked. So you always want to look and see how that belief system is influencing how they act in life, how they behave, how they interact with others, the kinds of things they say or choose not to say when they're with people, or the type of situations that they get themselves into, how those are related directly to their views on life. So in a way, with CBT, you're trying to, one thing that you're trying to do is get the patient to see things differently. You could use the word brainwashing or unbrainwashing or rebrainwashing. You're trying to get them to take on the philosophies in life that people who don't have depression or anxiety or anger issues seem to have. And through CBT, over time, you're trying to get them to take on these philosophies that appear to be healthier and help people live happier lives. To do that, you have to start thinking in terms of what their philosophies are, so that you can start seeing where the problematic belief systems are. Let's look at the principles of a CBT session, things that should be in the background of your mind during a CBT session so that it is actually fitting with what we know of as CBT. The therapist's demeanor. Now, these are the famous, well-known humanistic traits that every therapist should have. Genuine, interested, respectful, caring, confident. I would add to that. You want to be present. The patient should feel that you are listening and paying attention. So with the confidence, I don't think you have to pretend that you know everything, or that you're confident that this CBT is 100% effective for everything. Even confidence in not knowing, or being confident that this is a mystery, something like that, I think is helpful for patients to either model that take on things, or to at least feel that they're with somebody who is solidly grounded, even in situations where you're solidly grounded in being okay with not knowing something, but still being confident that that's okay. Also, in the CBT sessions, particularly at the beginning, you want to be thinking about socializing the patient to the CBT. You want the patient to feel that this is collaborative, and you do that by stating in the very first session that this type of therapy, CBT, is a collaborative approach. And when I'm working with younger people, adolescents or kids or young adults, I'll even point out that in society we're usually taught to be respectful and smile and agree, and that that's the right way to be, even in situations where you don't necessarily agree. And then I let them know that we need to get rid of those rules, and in this setting that it is welcomed and invited to have some skepticism, and not to believe everything that I say just because I'm the one that said it, and that they should examine their own lives and their own experiences to see if what I'm saying might be true, and to test it. Or if I say something that seems wrong from their standpoint, or they have, I'll tell them that if I say something or present a theory and they have had experiences that prove that to be incorrect, they should bring that up and discuss it. So that's part of the collaborative part. And empirical, the fact that we're going to be using logic, looking for evidence for and against certain beliefs, looking at reasons to believe that one approach, if let's say we were doing some kind of therapy homework where the patient is going to try to open up a little bit more. And so we maybe would set up an experiment where the next time they're talking to their friend, they're going to share a little bit more information that might have an emotional valence to it. Not too much, but do it as an experiment where the patient is then monitoring how it feels for them to do that. They're monitoring what kind of response they get from the other person, etc. There's also a well-known strategy with social anxiety for people who don't understand why nobody's talking to them, and meanwhile they're walking down the corridors of their office or the school hallways with their head down and not talking to anybody, and then they use the fact that nobody said hi to them or talked to them as proof that they are an outcast or that they're a source of embarrassment of some sort. So we'll set up an experiment where there'll be a quota. You have to say at least 5 people hello and smile and look at them, and keep track and monitor how many hellos you get back, how many smiles you get back, how many people just turn the other way and don't say anything. So you do things in life where you're making changes and you're monitoring it, and that's part of the empirical way of understanding the world. Psychoeducation, letting the patient in on all this knowledge that we have, letting them understand how we understand depression, what causes depression, what are we likely to see in someone who's depressed. Help them understand that CBT is an empirically validated form of treatment that has literally thousands of studies backing it up. So that's helpful also in going back to the stance of confidence in the likelihood of CBT being effective, but educating the patient in some of these things so that they're more informed about them. This is particularly important. I mean, it's important in all CBT therapy, but it really gets a highlight, especially when you're working with anxiety patients on phobias or OCD patients, where you're going to be doing exposure therapy, for them to fully understand the physiological aspects of what anxiety is, why it's there, and we'll talk more about that when we're looking at some of the strategies. But you'll see that a patient is unwilling at first to do exposure therapy, where they're going to actually be doing the very thing that makes them freak out, unless they understand neurologically what's happening in the brain, how this experience is going to change the brain physically, or at least change the functioning of the brain and how that works. So that kind of psychoeducation is very important. The use of Socratic questioning. Instead of explaining to the patient that you've figured out what's going on, here's the belief that's giving them trouble, and here's how to fix it. It sounds like you could save a lot of time, and maybe once in a while there's a place for that. But in general, what we need to do as therapists is be clever and strategic in coming up with the right questions that will get the patient to think that they've figured this out for the first time. So it's very tempting to, let's use an example. Let's say you're doing an automatic thought record, a dysfunctional thought record with a patient with anxiety, and they were talking about, a common one is they're at a party or some sort of social gathering and they're just silent, they're not talking, and we're doing the thought record, and some of the thoughts are that they would say something embarrassing, or they might say something offensive to somebody. And then we would do the downward arrow, where you draw a little arrow under that and you ask, let's suppose that did happen, because that is a realistic thing, that happens sometimes. What if that happened? What would be so upsetting about that? And they'll say, that people will think they're weird, or that they will look foolish or stupid. And then what if that happened? What if you could do a survey theoretically and you found out that some people did think that you were foolish for what you said? What would be the most upsetting thing about that? And you do this downward arrow, and most of the time it ends up with the person saying, with anxiety, it's usually something like, people won't like me, I won't have any friends, and I'll be alone. And so when you're already starting this process, it's so tempting to say to the person, I know what you're worried about. You're worried that you're going to say something foolish and that no one's going to like you and they're not going to want to be friends with you, and you're worried about being alone, because that's the human inherent need to be belonging to the group and be accepted socially, and you're worried that that's not going to happen. And then you could save about 3 sessions in the patient eventually getting to that. But it will not stick, and they may agree on the surface, but it's not going to have the same kind of impact. The one with depression is usually similar, where things aren't going to go right, then people won't like them, and they'll be alone. But sometimes it can also be that they are ineffective. They're unable to meet the demands of the demands of human society, or something like that. So it's either I'll be alone, I'll be ineffective, or dysfunctional, something like that. So keep in mind that we want to use Socratic questioning and help the patient come to some of these conclusions on their own. So let's look at the elements of a CBT session in a practical sense, some of the things that should be in these sessions. If we were looking at a video of a session and we're looking to see if it has aspects of a CBT session, there would be the brief update. You want to do a mood rating, find out how the week's been going. I usually have the patient rate on a scale from 0 to 10 or 0 to 100 on a happiness scale, how their mood's been that week. Check medication compliance, if they're seeing a psychiatrist, any changes to the medication, etc. And then you want to bridge from the prior session to the current session. And I'll usually go through my note and remind the patient what we talked about and what the homework was, and so forth. So then that gets them up to date, so we can kind of continue on from where we left off. Then we set the agenda. I always ask the patient, is there anything that happened this week, or anything at all that's ever happened that you were thinking was something that would be helpful to talk about? Any problems that came up that we should be working on trying to solve? Any upsetting incidents that you were thinking about that you feel that would be helpful to either change, work on, or just vent about and talk about it to get the feelings out? And so we write those things down on the agenda so that we make sure we have time to talk. And of course, we review the homework. A few reasons for this. Obviously, the homework is important, so we want to review it to get the benefit of having done the homework. But it also sends a message to the patient that this is actually a thing that needs to be done, and we're going to be looking at it. If you don't review the homework, it sends the opposite message, that this is just sort of an idea to make it seem like therapy, but if you don't do it, it really doesn't matter. You want the patient to understand that people who do the homework seem to get the benefits of therapy. A very common incident is with the thought records, where the patient will say that they didn't actually write down anything on the thought record, but they were thinking about their thoughts. And that one's a tricky one in helping the patient understand the benefit that they would get from doing the thought record. So any homework that doesn't get done, you can actually just do it in the therapy session itself. And it would be more beneficial for the patient to do it outside of therapy, so that they're getting the experience and they would be being able to move on to the next piece of the CBT session. But either way, the homework's got to get done, whether it's in the session or on their own. And then, of course, you discuss the agenda issues that the patient had. Then toward the end of the session, there will be a point where the new homework assignment is given, and then we do a little feedback summary. I usually ask patients, how did this session go? Did it seem like we focused on the right thing? David Burns talks a lot about having patients write on a piece of paper little check-off boxes on everything. And he insists that they all have to be checked off in the far right-hand side of perfection. So that's something to think about too. A lot of times patients, to be socially nice or friendly, will say, yes, everything was fine. Especially patients with anxiety who don't like conflict. You're going to see a lot of those patients. They'll say everything was fine, everything went well, it was a good session, and then they don't reschedule and you never see them again. And they're exhibiting the avoidance that usually goes with anxiety. So it is important to at least let the patient know that you're interested in doing a good session. And it kind of sends the message too that there could be a I won't say wasted, but there could be the chance of not focusing on what's most important. By asking the patient for some feedback on this, it kind of gets them to think also that they should want and be looking for a session that is helpful, on point, focused on the aspects that the therapist and the patient think are the most beneficial, so that it doesn't start to get diverted. Okay, so the patient's here. You're having your first session, the initial intake session. I don't want to spend a lot of time on this because this isn't really particular only to CBT. It's more of a good therapist practice that in the first session you get a good history of the patient. But I thought it might be helpful to at least list the categories that could help direct an intake session to be the most effective. So in a clinical history interview, you want to look at any medical problems that the person has, or any major previous medical problems, any head injuries, anything like that. Educational background, how far did they go in school, and their employment, or how did they do in school, any problems with the educational process, and then the employment, where are they working, what other jobs have they had, does there seem to be some kind of a trend in either getting fired, or are they more the person who keeps jobs for long periods of time, etc. Any military history, and then the psychosocial background, which I would break that down into who do you live with, who do you associate with, how do those interactions go? Do you get along with people? Are you arguing a lot with people? Exercise habits, sleep habits, eating habits, that kind of overlaps with the medical, but also could be part of the psychosocial background. Any substance use issues, you want to understand how that may be affecting the patient. You want to look at any previous or current psychiatry. When did the patient first enter therapy? When did they first start medication? That sort of thing, so you can kind of understand the progression of the problem. Also in this one, you want to find out other therapy that the patient's been in and find out if they've had a CBT therapist in the past. And Dr. Gilson pointed this out in his presentation, that a lot of times patients will say that they've had CBT, or their previous therapist was a CBT therapist, and then within one or two questions asking about if they've ever learned about cognitive distortions, or if they've ever done a dysfunctional thought record, and you start finding out that the person does not know, or has not been in CBT before. Or if they have been in CBT, was it helpful, was it not helpful? Maybe talk about some of the topics that they focused on, and how that went, and why they're not seeing that person currently. And that can be helpful in, if they were seeing a therapist, whether it was CBT or not CBT, and you find out what it was, if there was something about that therapist that seemed unhelpful to the patient, that is a good thing to know, so that you can, one, try to avoid it, but two, also alert the patient that they should let you know if it seems like it's heading down that same path. let the patient know that you don't want to make the same mistake that other therapist made, and if they notice it happening, to bring it up. A problem timeline is helpful. I even have a form that's basically a line, and you can mark it off into the years, find out sort of when, let's say it's depression, when did the first episode possibly happen? And you can mark in the time that it was, and you can also write in notes about what was going on, what might have triggered that depressive episode. And then the familial psychiatric history. Is there depression in the family, anxiety, OCD, eating problems, etc., to try to understand some of the genetic factors that might be playing a role here. Okay, so there's a lot to cover in the initial intake session, and oftentimes it's helpful to think of the initial intake session as taking 2 sessions to complete. So we were saying before that with insurance, one of the practical things you need to do is have a diagnosis by the end of the first session. So you want to be able to have some time and see if they meet the criteria for a depressive disorder or an anxiety disorder, or at least use one of the unspecified anxiety disorder or unspecified depressive disorder or something like that. Now, if it's something like a phobia or OCD, there are different measures and questionnaires that you can use. I don't want to spend a whole lot of time on that because, again, that is part of regular training and not specific to CBT. Probably one of the most common questionnaire surveys related to depression is probably used by CBT and non-CBT therapists, but it's the BDI-2, the Beck Depression Inventory, second version, which you're supposed to purchase, like this one. It has the color on it. And it goes through 21 items, and the person rates on a scale each category. So sadness has 0 through 3. 0, I do not feel sad. 1, I feel sad much of the time. 2, I am sad all of the time. 3, I am so sad or unhappy that I can't stand it. And then there's an item for pessimism, an item for past failure, etc. One of the ones that you want to definitely look at and ask specifically about whether you're using the BDI-2 or not in that initial intake session, especially if depression is one of the things that's going on here. Number 9 on this one, suicidal thoughts or wishes. 0, I don't have any thoughts of killing myself. 1, I have thoughts of killing myself, but I would not carry them out. 2, I would like to kill myself. 3, I would kill myself if I had the chance. So you want to look at that and gauge whether you need to go in and do a more thorough suicide possibility evaluation. Also, as part of the intake session, usually even if you haven't finished the whole intake interview, there should be some time to set aside to explain the CBT model. When the patient leaves that session, they should understand that you're going to be working with that patient in a CBT capacity, and you should explain to them what that means. You want to describe the 3-part model, the thoughts, the feelings, and the behaviors and how they're connected. You want to show them that diagram and talk to them about how this therapy is going to be focusing on changing their emotions by looking at their behaviors and their thoughts. So also in that first session, you should let the patient know that there is a structure and a format to the sessions. And you can even break it down and let them know that in every session there'll be part of the time reserved for talking about things that they find useful on the agenda. You should let them know that there's homework involved in CBT. You should let them know that in every session they will likely, hopefully, be learning something new, either learning something about what we know about depression in general, or something about themselves, or learning some new strategy or technique that they're going to be trying to implement that week. But they should always leave with something that they're going to try to apply during the week. Also, in the first session, you want to set goals, and that's a whole skill set in itself, is helping the patient set goals for therapy so that they are realistic, and it helps keep the therapy on track. The other aspect in the first session is the homework. So oftentimes the first homework assignment goes along with the goal setting, and what I'll do, I'll get out a card and I'll write on it, if therapy is working, what will change or be different? And I'll ask the patient, let's suppose it's several weeks down the road and you were to say to yourself, this is really working, this therapy is really effective. What would we see differently that would make you say that? It's usually things like improve my mood, get out of the house more, have less arguments, things like that. Speaking of goals, some of the goals that you should have as a therapist in that first session, so let's look at these. You should be aware that you're trying to establish rapport. So you're trying to include those aspects of being genuine, attentive, enthusiastic about what you're doing, and confident in order to build rapport. You should, by the end of the first session, feel that you have socialized the patient to CBT by explaining to them what CBT is, about the homework, about how it's empirical and how it is collaborative, that sort of thing. The patient should leave there feeling that they understand a little bit more about the disorder or the diagnosis, if there is one. You as the therapist should make sure that you've educated the patient about the process of therapy, like we've just mentioned. In that first session, you should help to normalize the patient's issues. Help the patient understand that they're not the only ones that have this going on about them. And you can also let them know that there are clinicians and researchers who have dedicated decades of their lives to studying just this sort of thing, and that they're not alone, and that the symptoms that they're having are understood, and that we do have ways to effectively treat them. So you're instilling hope and letting the patient know that what they have going on is something that we know something about. And it is actually true. It's very rare, after practicing for a while, it's very rare that somebody would come in with some new set of symptoms that makes me confused and not know what to do about it. So it really is true that, although there are a number of different disorders, and obviously no two people are alike, there are these commonalities that seem to run through issues and the way people coming in for treatment go about it. Another part of the first session is to try to, the therapist's goal should be to try to find out what was the person expecting to get out of therapy. There are some patients who are really not interested in CBT, and if you're going to work with them and they're not looking for CBT, they want more of just supportive counseling or maybe life coaching or something like that, it's probably good up front, if you're going to stick to the CBT model, or if you're going to transition out of that role, at least you and the patient would agree that you're going to try this new strategy and not CBT, instead of letting them believe that they are doing the evidence-based CBT therapy. So the other thing you want to do when you're working with a patient in the very beginning, in the first session, is to try to understand what the patient's expectations for therapy is. And I always ask patients, did you come here because you know about CBT and you know I specialize in that? And sometimes that's the case. The person was seeking out CBT, and either through recommendations or looking on certain websites, they discovered that I was a person that specialized in that, and they have read about CBT and that's what they want. Most of the time, however, these days, people will say that they've heard of it. Several years ago, people didn't even hear of it before. But for the patient to understand that you specialize in CBT, and this is the type of therapy that they're going to be engaging in, is very helpful to know up front. Most of the times what I find is that the patient feels more and more relieved the more you explain to them what CBT is and how it works. But there are going to be some patients out there who are not interested in the kind of therapy that CBT offers. And they are maybe looking more for some kind of just supportive therapy, someone to vent to, somebody that they can bring their spouse in so that you will tell that spouse how wrong they are and how they should act. People are looking for different things in therapy. So if you can at least explain to them what CBT is, and if they are resistant to that, they don't see the value in it, they don't want that, then you've got a choice to make. Are you going to stick to CBT and have them find a different therapist, or are you going to, if you have other skill sets besides CBT and you're going to offer them that, at least it's agreed upon up front that we're not doing CBT. We're going to be doing this other type of therapy, whatever it is, or maybe life coaching or something like that. But at least you know what the patient is expecting to get out of therapy, and then you've decided whether you're going to cater to that or not, or socialize them into CBT and helping them understand that this is the type of therapy that they should want. And then, of course, in that first session, you should be understanding more of getting more information about the patient's difficulties and how it's affecting their life. So by the end of the first session, or at least by the end of the second session, if you're kind of spreading out this intake process into 2 sessions, there should be some set goals, and in practically every session we should be looking at those goals and asking the patient, are these still the goals, or should we change it? Have we met them and now we need to add something else, or maybe they're not important anymore, as important as the patient had originally thought. But in every session, those goals are going to be very important for knowing what we should be focusing on. So let's talk about the goals. Everybody these days knows about SMART goals in a business sense. I don't know if we need every part of that acronym, but they should be specific. The more measurable they are, the better, even if it's measurable on a subjective unit scale of happiness, how the mood rating, in a way, is a way to measure the mood. But if you're able to count how many angry outbursts did you have, how many hours did you spend socializing this week, how many times did you check the locks to make sure they were locked, for example, if you were working with somebody with OCD, checking behaviors. So the measurable goals are very helpful for seeing if you're making progress. There should be a realistic time frame, knowing that probably in one session you're not going to have cured this person of depression for the rest of their lives. So if we're looking at realistic goals, let's say for depression, the patient should know and understand the common course of depression, the fact that it comes in these waves, these episodes, and that a lot of times you can pinpoint a particular day or week when the mood shifted. They should understand that these episodes tend to last several weeks to several months long. And if we're looking at the evidence of research to understand what can we expect reasonably to get out of CBT, if it's done appropriately, I let the patient know, 1, the frequency of episodes would be much less. So in the lifespan, there would be fewer depressive episodes than if they hadn't had CBT. I also let them know that the episodes tend to be shorter. So instead of lasting weeks to months, maybe it would last for a few days or maybe a couple weeks. They should also know that they could expect that the episodes would not be as severe. So it's the severity, the duration of the episode, and the frequency of the episode are all lessened and diminished in general for most people that go through CBT with depression. Some examples of goals that seem to be popular is improve mood. And then if they say that they want their mood to be better, you can elicit further goals by saying, well, let's suppose your mood were better. What would we see differently? And then it's usually things like getting out of the house more, improve schoolwork, less worrying about tests, meet more people, argue with spouse less, things like that. So these are examples of goals that are measurable, they're realistic, and they're specific. So let's look at what some of the common homework assignments tend to be in CBT. The very first one is usually to refine the goal list. So I had talked about having that card that asks the patient if therapy's working, what would change or be different, and we'll work on it in session, and then they'll take it with them, and during the week they can think about situations that come up that might remind them of other goals that they'd like to work on in therapy. Another homework assignment is the dysfunctional thought record, or the automatic thought record, where the person would be keeping track of situations that come up that they have strong thought and emotional reactions to. Adding items to the agenda list throughout the week. You would think that patients would come in and they'd have a full agenda. They have been thinking about therapy, they've been in the waiting room, that they're going to come in and they're going to have a list of topics to talk about. And I don't know if it's my style or CBT in general, but I do find that a lot of times patients come in, and if you don't specifically ask them what happened this week, that you want to make sure we have time to talk about. Because CBT is structured in the way that it is, I don't know if that's the reason or what, but I do find that a lot of times patients will start thinking in that moment that you ask them what they should possibly talk about. One of the homework assignments would be to alert the patient that during the week they should be keeping track of events, situations that cause emotions in them, and just jot down what the incident was. You know, the oatmeal incident, the broken light bulb incident, so that when they come in, they will already have in mind at least some incidents that occur during the week that is related to what the goals of therapy are. Sometimes the therapy can be to read a particular article or read a certain chapter in the book. Reviewing the coping card. I have a drawer with cards, the coping cards, the famous CBT coping card. Anything that comes up in therapy that seems like it would be useful for the patient to remember during the week, we put it on a coping card. So for example, if we were learning about how to use mindfulness, we might write down the 3 tenets of mindfulness so that the patient can remember what they are when they're trying to apply mindfulness that week. Or a lot of times we'll put the common dysfunctional thought that comes up. So the person knows they're going to be going to a social gathering that week, and they know when they get there they're going to start feeling anxious, and they're going to start telling themselves to not say anything because everything they say is going to sound so stupid and get judged, and everyone's going to think they're an idiot. So we'll write a few of those primary thoughts on the card. You know, everyone will think I'm an idiot. Don't say anything. Anything I say is going to sound stupid to these people. You know, whatever it is that seems to come up over and over again. Then on the other side of the card, we can write the more realistic after we've discussed it, and we realize that through the patient's own observations that almost everybody says things that are either irrelevant, didn't mean much, weren't on topic, weren't the perfect thing to say, and that it's okay, and that not saying anything might be more of a social faux pas than saying the wrong thing. Or people usually respond to what I say with interest, you know, something like that, if that's what the patient has observed. But something that will help the patient when they're actually in the situation, when the negative thoughts are occurring, that they could know that that card's there and actually get it out, maybe go to the restroom and read it to themselves, and in the moment remind themselves of the more realistic way of looking at it. Another example of a homework assignment would be to set the reminder to go to bed at 10 o'clock p.m. That would be obviously somebody who's wanting to work on some of their sleep hygiene behaviors. Make 3 positive comments to children before bed. That would be somebody who's possibly working on improving their interactions with their kids or feeling as like a more competent parent, something like that. So these are measurable, they're specific, and they're realistic goals. So there have been some studies that have indicated that patients who do the homework actually get more benefit out of CBT, and that's always helpful to let patients know that if they want to up their chance of getting out of this as much as they can, doing the homework is one of the ways to do that. And then we talked about getting feedback toward the end of the session. And you can do that directly by just asking the patient, did it seem like we focused on the most important things? Is there anything I said that you wished I didn't say or that you didn't like? Is there anything that you found particularly important in today's session? So I think that helps the patient. I think it sends the message to the patient that you want the therapy to be effective for them and you want it to go well and you're interested in them and their view of the session itself. Another way to do feedback is the way we were talking about before, where you could have a little questionnaire that the patient would fill out and turn in at the end of each session. So questions on a therapy report like that would be things like, did you feel listened to and understood today? Was there anything that bothered you about therapy today? And then any suggestions. So there you have it. What should be in that initial or the 2 initial sessions? What about the next session? This would be either session 2 or possibly the session 3 if you were extending the interview and the information gathering and the socializing. Typical CBT sessions from then on out usually tend to follow this particular format. You do an update, find out what the mood rating is. You do a bridge from the previous session by reviewing what you had talked about. You set the agenda, you review the homework, you discuss the agenda items, and then you assign a new homework assignment and the summary or feedback. So we talked about the therapist's goals in the first session. In the following sessions, the therapist's goals should be to get the patient to select the focus, talking with the patient so that the patient is starting to take on more of the leadership role of the therapy session. The goal should also be looking at solving some of the problems that are coming up for the patient. You want to keep reinforcing the CBT model, and you want to continue socializing the patient into CBT so that they start to take on these qualities. The way that the therapy is done starts to be the way that the patient interacts in the world. So that if you're in CBT sessions, and you've had several sessions, and you're starting to look at things from an observer, from a non-critical observer, you're starting to look at things from, how can I solve this problem? Or you're starting to look at your own thoughts as automatic processes that pop up that can be examined and looked at. You're doing that in session, but the patient should start to take that framework from the session into their real life, so that when they're having an incident in their real life or interacting with somebody, they're starting to look at it from an observer, a problem solver, someone who doesn't have to buy in to their initial beliefs and ideas, and can instead look at the situation more, analyze it a little bit better using these strategies that you're using in therapy. So as therapy progresses, we should start seeing a couple shifts. The therapist starts to, they're still collaborative, so we don't want to say you totally drop out of it, but the leadership role starts to become more of the patients, where they are coming in and they're starting already to tell you how their week went or what their agenda is without needing to be asked, and they start deciding what would be a good strategy for a homework assignment so I can work on this. So they're starting to become their own therapist in a way. Also, there's a shift from automatic thoughts. So in the beginning of therapy, when you're first doing these dysfunctional thought records, you're looking at more at the surface conscious thoughts the person had. For example, like we were using the example before of the person who's going through the social engagement, and their thoughts are, anything I say is going to sound stupid. These people are judging me. If I say something, it's going to make me look in a negative way, something like that. So those are the conscious, aware thoughts. The second, I like to call it the second level of CBT, is where you start getting into more of the deeper schemas, the deeper philosophies that the person holds that causes them to actually have those automatic dysfunctional thoughts in real life settings. So for example, to make it more clear, that let's say that patient has the social anxiety and they have those thoughts. When you start getting into some of the strategies we'll talk about, you start to find out that not only does this patient think that what they say at that party is stupid, we start to find out that they really have a deeper philosophy about themselves as being not very important, or not being intelligent, or maybe their views are more about the criticalness of people in general, or something like that. Then you start realizing that it isn't just that social engagement that's making them nervous, it's their whole sense of their own ability to match up to the expectations of intelligence that they think the world has for them. So that's where the shift starts to go from these automatic thoughts in the moment to deeper assumptions and core beliefs that need to also be changed in order for the person to reach their therapeutic goals. Documentation. So what does a CBT therapy note look like? This is a common one. This is the way I do it. It would be longer, but I've summarized it into the main parts. The therapy note obviously should have the name, the date, possibly what session number the person is in. You could also have things, practical items like what insurance they have, the diagnosis, etc. If you do the BDI-2, or you're doing the Beck Anxiety Inventory, or any type of measure, then you could put those scores in the therapy note. Then there's a session focus portion. This example says, discussed school difficulties, feeling less depressed and anxious this week. Mood rating equals 75 out of 100. We did this a dysfunctional thought record, and the dysfunctional thought record was, the English paper is due tomorrow. That's the situation. The thoughts are, it's not good enough, I don't have what it takes to succeed, and there would probably be more on an actual note. The emotion was anxious, 85. The homework was to read chapter 1 in Overcoming Depression and do another thought record. And then we've got a plan. If you're doing notes, a Word program, or if you have electronic notes, better yet, either way you can pull up the old note. You can keep the background history, change things if some aspects of that have changed, and just change the session number, the session focus, put in the new homework. But you can also look at what your previous plan was. If you knew it was time to start discussing cognitive distortions, you'd put that in your plan so that in the next session you would see that. Let's talk about the CTRs. That's the Cognitive Therapy Rating Scale. It starts off with a scale from 0 to 6. 0 is poor, 1 barely adequate, 2 mediocre, 3 satisfactory, 4 good, 5 very good, 6 excellent. So this is where the therapist would either rate themselves or they would get somebody else to rate a video of a session. And then it goes through 11 categories: setting the agenda, eliciting feedback, showing an understanding of the patient, interpersonal effectiveness, collaboration, pacing and efficient use of time, guided discovery, focusing on key cognitions or behaviors, strategy for change, application of cognitive behavioral techniques, and homework. Let's look at an actual copy of the CTRs. At the top, we've got the name of the therapist, the patient, the date of the session, tape ID number if you were doing this in a clinical setting where there's a recording of it, the rater, and the date of rating. We've got the session number, what type of observation it is: videotape, audio tape, a transcript, or a live observation. For our purposes, I would say we could even add to that self-review of session, which obviously is, sometimes it's hard to see the back of your own head in a mirror, in other words. So it's sometimes better to get feedback from another person to point out any issues that we might want to work on. So there's that scale again, 0 through 6. And so for agenda, they've got 0 would be the therapist did not set the agenda. A 2 would be the therapist set agenda that was vague or incomplete. Number 4, therapist worked with patient to set a mutually satisfactory agenda that included specific target problems, for example, anxiety at work, dissatisfaction with marriage. A 6 would be the therapist worked with the patient to set an appropriate agenda with target problems suitable for the available time, established priorities, and then followed agenda. To be a good CBT therapist, you need only to look at the number 6 description for each of these categories. So for example, feedback. What you want to do is to seem to understand the patient's internal reality thoroughly, and to be adept at communicating this understanding through appropriate verbal and nonverbal responses to the patient. For example, the tone of your voice, the tone of your response should convey a sympathetic understanding of the patient's message. And you should show excellent listening and empathic skills. If you want to have the best interpersonal effectiveness, you should display optimal levels of warmth, concern, confidence, genuineness, and professionalism appropriate for this particular patient in this session. If you want to make sure you're meeting the criteria for collaboration and you want it to seem excellent, you should encourage the patient as much as possible to take an active role during the session. For example, by offering choices so they can function as so that the two of you can function as a team. So there you go. All of you should have received a copy of this so that you can look and see what to include in your therapy sessions. Right, now for the good stuff. These are the things that makes a CBT session particularly exciting and interesting to be a CBT therapist. I've conceived it as having an intervention menu. And I have to say, I can't say that it would apply to every patient 100%, but I think it's pretty close. In my practice, once we go through this, you'll see that these strategies seem to cover mostly every manual that I've seen, patients that I've worked with, etc. So let's look and see how this outline works. So number 1, we've got interventions, strategies that focus on changing or fixing or solving some problem. I'm going to skip ahead for a second so you can see what number 2 is. Number 2 is not changing, fixing, or solving. It is mindful acceptance, the opposite of changing or solving. So let's go back. So we're going to have 4 categories that all focus on changing, fixing, or solving problems. Letter A, cognitive restructuring. So this is basically a fantastically brief summary of cognitive therapy. Number 1, the patient is learning how to notice and acknowledge their thoughts. Number 2, they've developed the skill of spotting their cognitive distortions and noticing the false thoughts that they have. Number 3, they're generating more logical and less emotional perspectives. They're coming up with the alternative ways of looking at things. So that's basically the 3 parts of cognitive restructuring. And there's a whole list of strategies developed specifically for getting a patient to improve on those skills. The other category, the second category, is letter B, behavioral interventions. A lot of the interventions, the strategies, will involve getting the person to exercise. These strategies could involve getting these are actually what the research shows helps a person get out of depression. You've got to exercise. You've got to be engaging in activities that have some skill level or mastery level, playing an instrument, doing a sport, even watching movies. If you're a film aficionado and you're analyzing the director's techniques or the acting techniques that are being used, or you're looking at the writing of the dialogue and you're critically watching a film, that can be an enjoyable activity that involves some skill level to it. Socializing, being around people, positive social support. Another example of a behavioral intervention would be exposure therapy for anxiety and phobias and OCD. Some interventions, this is still regarding changing or fixing or solving things. Most CBT manuals will have some area where they are focusing on helping the patient solve problems better. Now, I've looked at probably a dozen or more books, modules, worksheets, etc., all proposing to teach a person how to solve problems. And they all have a different acronym, but they all seem to focus on these 4 abilities. So these are all sub-skills of the overall skill of problem solving. They all say you have to identify what the problem is, or identify what you want. Then there's always a portion where you are thinking it through, trying to generate a list of possible solutions. Then you look at these solutions. When you're generating the solutions, you're brainstorming. You're not supposed to be crossing them off the list too soon. Once you've got them written down, then you're evaluating each possible solution for its pros and cons, what will be the best way to handle the situation, and then you actually try the best solution to optimize your chance of getting what you want or solving the problem. So a lot of interventions in CBT will focus on helping this person engage in these steps of problem solving. Another skill that is related to problem solving, but a little bit different, or maybe more specific, is negotiating. And this can also be broken down into learning how to be empathetic, and all of the books on assertiveness training or negotiating or working with teens and parents on how to dismantle their arguments and solve the problem together all have to do with empathically trying to understand the other person's motives and perspective and concerns, how to explain your own motives, concerns, and perspectives, and then working with the other person to come up with some type of solution that you can agree on. So the strategies in CBT will sometimes focus on this in order to improve social interactions. The second category is the mindful acceptance. Usually the way I present it to patients is that we're trying to learn these skills to change the way we think about things, which will affect our mood, or we're trying to solve problems. We're trying to make things go the way we want them to be, the way we prefer them. We're negotiating, also in an effort to change things and get things to go in the way that we want them to. Or we're learning things that we can do differently in order to feel better or improve our sense of well-being. Then there are going to be times where it worked a little or it didn't work at all, or it worked a lot, but there's still some residual negative mood, or this relationship with this person still isn't perfect, or the solved part of the problem, the solution was partially effective, but there's still some downside to it, something like that. Something where we can't get everything to match our level of comfort or the way we prefer it. Then we talk about mindful acceptance, mindfulness, a concept that's over 2,500 years old, but just starting to gain traction in the last decade or so in modern Western psychotherapy.